What I'd like to do today is basically take you through some of my thoughts on immune reconstitution after stem cell transplantation. And before I begin, I wanted to put a little plug-in for the ASBMT Clinical Case Forum. So for those of you who have not sort of seen this yet, this is a new initiative that we're launching at this meeting, which is basically an online web discussion forum where we can discuss challenging cases. So this is open to all members of ASBMT and is also open currently to all attendees at this meeting. And therefore, if you have any interest in casing, any challenges cases that you want to bring to the group, we certainly encourage that. And we really want to have this as a living tool that all of us can benefit from. And the other thing I'd like to do today is, bring us into the modern era of social media. So, as I'm talking, I'm retweeting the references for this talk. So if you have any questions and you want to go back and see some of the references, you can follow my Twitter feed, and all of the references will be listed and linked to the actual paper. And in order to do that, you can follow the hashtags BMT-CEC. And I encourage you, all of you, to join in on that. So why is immune reconstitution important? This is a slide that I'm sure you've seen a million times at this meeting or other meetings, which looks at the causes of death after transplantation, and this is CIBMTR data. And you can see that whether we're using autologous transplants, HLA identical siblings, or unrelated donors, infections here in pink account for a substantial number of complications. And infections are tied to immune reconstitution in large part. So the topics I wanted to cover was give you a little bit of background in immunology. I actually wanted to spend some time talking about some of the assays we use to look at immune reconstitution. Because I think oftentimes we sort of see lab reports or people talk about a CD4 count or this or that chimerism, and we don't necessarily appreciate what's going on behind the scenes, how we get that value, and what it actually means. And I think we're really entering an era where the tests that we're using for immune reconstitution are becoming much more sophisticated, and so I think it's important for us to start to use these tests and also understand what we can do with them. And then finally, obviously, I'll talk about immune recovery after transplant. So this is how we see the immune system. So this is looking at B cells, dendritic cells, monocytes, and natural killer cells, and you can see that for many of these cells, they're actually subset populations. And my focus is primarily on T cells, and T cells deserve a slide all to themselves. Basically, you can have CD4 cells and CD8 T cells. Each subset is then subdivided into different subsets of naive memory and effector memory and central memory cells. And then CD4 cells can also be regulatory T cells and also Th17 cells. And we're really starting to look at these different subsets in the context not just of transplant, but also immunotherapy in general. And some of these subsets are very relevant to cancer immunotherapy and some of the new drugs you're hearing about, like checkpoint blockade drugs. So let's talk about immune assays. So one of the most commonly used assays is flow cytometry. And the way that works is we basically take blood from the patient, we label the cells with antibodies that have specific fluorochromes, so different antibodies have different colors, and then you put the cells through a very fine tube that you're basically looking at one cell at a time, and you use a laser and then you can detect different antibodies. And so, for example, here illustrated is CD3 cells, and you can see that they're made up of CD8 and CD4 T cells. And these are the so-called killer T cells that will eliminate viral infections, and CD4 T cells are the helper T cells, the ones that are affected by the HIV virus. So actually people have gone together and have developed panels that they're recommending for phenotyping. And I think this is really critical as we move forward with more complicated analysis of the immune system, that we use the same types of panels. And so these were studied, and they basically recommend specific colors be used in specific settings. And I think for us to move forward in a way that we can compare data from different centers or studies done at multi-centers or at different times, that we agree on common standards so that the data can actually be useful and we can meaningfully compare data from one center to the other. One of the other assays that we have is something called the tetramer. So flow cytometry can use many ways. When we look at T cell subsets, basically we're looking at defining different populations of T cells. But that doesn't really tell you what these T cells do, or more importantly, what do they recognize? Are these viral-specific cells? Are they tumor-specific? And if they're viral, which virus do they recognize? So the tetramer assay is a test that allows you to identify which cells are specific for a particular protein. So for example, you can have tetramers that are specific for CMV, and so in the appropriate setting, you can actually detect what is the percentage of T cells in a patient that are specific for the CMV virus. The tetramer assay just tells you which cells recognize the CMV virus. They don't tell you if those cells actually are able to function or if they're able to do anything. They could be completely inert and really essentially useless from an immune perspective. So because of that, we've developed what we call functional assays. And so the ELISPOT is one of those assays where we look at the ability of cells when they're stimulated to produce interferon gamma. And interferon gamma is one of these antiviral cytokines, so that gives you an idea, do these cells have the ability to kill? So the way we do this is we basically isolate CD8 or CD4 T cells using antibodies and a magnet, and then we plate them. And so this is your CD8 T cells. CD8 T cells are stimulated when they recognize a peptide in the context of the right MHC. They're going to secrete interferon gamma. Your plate is coated with an antibody against interferon gamma, so that will stick to the plate. And then you come in with a second antibody that's labeled that will also bind to interferon gamma. And so each T cell that's stimulated, that's on the plate, is going to secrete interferon gamma that will stay at that site and then be picked up by your antibody setup. So this is what it looks like. You can actually identify each individual T cell that's making interferon gamma. And so if you stimulate them with a control peptide, you see nothing. If you stimulate them with something relevant, like a CMV peptide, in somebody who has CMV T cells, you can see there's a lot of activity. And then in the old days, this was counted manually. Now there's equipment that can just do this automatically and give you an idea of what percentage of the T cells are actually responding to a specific antigen. Now the problem with the ELISPOT reader is that it's one-dimensional. So if I want to look at CD8s, I get one response. If I want to look at a subset of CD8s, I would have to isolate that subset. If I want to look at the ability of CD8 cells to make different cytokines, I would have to do multiple plates. So this is where flow cytometry is far superior to the ELISPOT assay, because in flow cytometry, we can look at multiple parameters at the same time. Routinely in clinic now, we're using 8-color flow. So that means you can look at 8 different things at the same time. But in research labs, we can go up to 12, 14, or even 18 colors now in some centers. So we really can look at multiple aspects of this at the same time. But the idea is the same. You have your CD8 T cells. You can now label them with multiple antibodies to look at what subset is affected. You stimulate them, and then when they're going to secrete interferon gamma, you basically insert a drug called refeldin, which is a poison, and doesn't allow the cell to export or to secrete the cytokine. And so it stays in the cell, and then you poke little holes in the cell with a chemical, and you get your antibody to interferon gamma inside the cell. So this is data from a study we did a few years ago in patients with melanoma who were being vaccinated with a melanoma vaccine. And this is looking at tetramer and interferon gamma. And you can see before the vaccine, there's no activity. And then as we vaccinate the patients, we can see uptake here in this area of tetramer-specific activity. And that correlates with specific interferon gamma activity. So what that's telling us is that these cells not only recognize the particular peptide that we use for the vaccine, but they can actually respond and make cytokines, suggesting that those cells can actually go and kill melanoma cells. And the other thing we can do is we can look at multiple parameters at the same time, and this is what we call polyfunctional T cells. So in the same study, we looked at several different cytokines at once that were being produced by cells. And cells that can make more than one cytokine are called polyfunctional. And why is that important? In studies with HIV, they've been able to show that the cells that have the better ability to kill the virus are the ones that are polyfunctional. So cells that just make interferon gamma have some activity, but the ones that make interferon gamma and TNF and IL-2, which are different cytokines involved in killing, have a much better ability to kill the virus. And so in this study, we showed that after the vaccination in the melanoma patients, we could show polyfunctional T cells, again suggesting that these cells are probably more potent in killing the tumor. So where has that moved now? The latest, the new kid on the block is this system called multiplex analysis using mass cytometry. And this really allows us to sort of move in the modern era where you can have a high throughput and look at multiple antigens at the same time and really got a lot of information out of it. This is currently sort of just being rolled out, so there's not that much data out there with using this technology, but I think it's really going to move the field forward. What is something else we can do? So we've looked at subsets, which tells us what kind of T cells are in there. We've talked about recognizing specific antigens. We've talked about function. But another aspect that's very important in the immune system is the repertoire. And what that's saying is basically we want to see how many T cells are there, how many different populations of T cells. Are they all the same? Are they what we call clonal or oligoclonal, which is often what we see in patients with disease? Or do they have a healthy repertoire, polyclonal repertoire, which means that they can respond to various attacks, various viruses? And the way we do that is we basically look at the specific genes that are on each T cell. So every T cell that we have has its own gene. And we can look at that. It's part of the T cell receptor gene. And that's why we have every T cell population recognizes a specific antigen, a specific virus. The cells that you have that kill the flu virus are not going to kill adenovirus. And so there's different ways to basically do this using techniques called PCR. And so what we did is we did it a little bit differently, because when you use a technique like PCR, which basically amplifies things millions of times, if you amplify every T cell differently, you can get bias. And so what you get in the test tube may not reflect what's happening in the patient. And so what we wanted to do was basically bring all the T cells on the same plane. And that's why we put this ligation here at one end. And then that allows us to amplify the whole population at the same time. And so we think that this method really allows us to get a better picture of what's going on in the patient. And this is basically the methodology. Once we've amplified all the T cells, then we do sequencing to really understand at the level of the DNA what's going on with each T cell. And this is an example here of a healthy donor. And this is a patient who's had an allogeneic stem cell transplant that was T cell depleted. And I think what this illustrates is, basically they have different T cell populations, but the key point here is the one in black, which is other. So these are the ones that are most common, but these are the other. And you immediately see that in a patient, there's much less other. And what that tells you is that in the patient, there's far fewer different populations of T cells. They have less diversity than in a healthy individual who has much more diversity. So now I'm going to switch and talk about actual clinical data for the reconstitution studies. So this is what happens during life in a normal individual. So initially we have a lot of naive T cells, and then as you encounter different pathogens, different stimuli, vaccines, flu, other insults, you start to develop T cell responses, and you develop memory T cells. And that's the reason we have memory T cells, that when we re-encounter the same pathogen, we can fend it off faster. And so over time, you develop memory T cells, and you have a high level of circulating memory T cells. But the problem with that is the number of T cells that can respond to new infections decreases over time. The naive T cell population goes down. And so as we age, our risk of infection increases, and this is what we call immunosenescence. And this may also be relevant actually to development of cancer. There are certain models that suggest that part of the risk of increasing cancer with aging is not just the fact that as we age there's an increasing number of mutations that can generate malignant cells, but it's also the fact that the immune system is aging and no longer has the ability to control the malignant cell. And again, this is another illustration of this, showing that as we age, we go from a situation where we have more naive cells that haven't recognized anything yet, and then as they encounter different insults, we switch to a memory profile. What's happening during transplant? Basically, this is sort of a stable individual, and during transplant, we basically shut down the immune system. With the chemotherapy, the radiation that we give, and sometimes antibodies like ATG or alemtuzumab, we completely we induce leukopenia in the patients. And so this is the critical period when the patients are most at risk for infections. This is data from patients undergoing autologous transplant. This is looking at a very simple test. This is the absolute lymphocyte count at day 30. So this is a test that we routinely get off our CBC. And what these investigators showed already several years ago is that in patients with lymphoma, if you measure the absolute lymphocyte count at day 30, that is predictive of outcomes. So the patients who already have a better lymphocyte count at that time have a better survival than those who don't. And that's true for overall and disease-free survival. So this is why it's important, the immune system. We know from this type of data that if you have better immune system recovery, your survival is going to be better. And this has been shown in multiple studies in autologous transplant, in lymphoma, in myeloma, in amyloidosis, even in breast cancer. When they were still doing autologous transplant for breast cancer, they showed the same difference. So what about in allogeneic stem cell transplant? Again, the same message. This is data that was published again a few years ago, and you can see this is overall survival. Again, is directly linked to early lymphocyte count. This is at day 21, the absolute lymphocyte count, and you could distinguish two populations, and this is the risk of relapse and infections, and again, low lymphocyte count, more infections, but also importantly, more relapse. And this is data from John Barrett's group at the NIH, where they did T Cell Depleted transplants, and they wanted to see if in that setting they also saw the same effect. And again, they confirmed these results. The absolute lymphocyte count at day 30 is predictive of outcomes. When we think more broadly about the different subsets of cells that recover over time, beyond the lymphocyte count, this is a study that looked at this. And so you can see that your CD56, those are the NK cells, tend to recover very early, usually within the first 30 days. And those are the cells that basically control HSV virus. And so the highest risk of HSV reactivation in the absence of acyclovir, which we all use routinely now, happens in the first 30 days. The reason we continue to use acyclovir beyond that is really to prevent zoster infection, zoster reactivation. And then you can see that your T cells start to come in, but they come in much slower than the NK cells. And this is looking at different subsets. CD8 T cells tend to come in faster than CD4. You can see that your B cells, the CD19 cells, come in around 6 months. And that's sort of what guides our ability to re-immunize patients. Because if you don't have B cells, you're not going to respond to a vaccine. And so a lot of the guidelines for immunization are based on these type of data. But you can see that some populations of cells never come back. And in this particular study, the naive T cells, in most patients, didn't return. And so that really then gives you the idea that these patients are just not going to be able to respond the same way to infectious complications. This is data from our own center, which is unpublished but currently under review. And again, this is looking at the recovery of the absolute lymphocyte count. You see that it recovers over time. This is CD4 count, and this is CD8 count. And this is a population of about 350 patients. And you can see that the counts recover over time, but that you don't reach the normal value. And the CD4 count, the normal value is around here, so we're just below that about 12 months. Now the reason the data tends to go down is actually an artifact. What happens is the patients who have normal CD4 counts, the doctors stop checking. The patients whose immune system hasn't come back yet, we keep checking and checking and checking, hoping it's going to come back. And obviously that's why it skews the data once you get below 12 months. At 18 months, it actually ends up down here. That's why we don't show it, because it doesn't really mean anything clinically. And then when we looked in our study, which is in patients undergoing T cell depletion, we were also able to show that immune recovery, looking at absolute lymphocyte count, CD4 count, CD8 count, was predictive of both overall survival and disease-free survival. So you're really seeing a theme here that there's a direct link between immune recovery and survival. Now, obviously, we've known for a long time, based on the HIV literature, that you can correlate the CD4 count with the risk of infection, and this is also true in transplant patients. This is work that was published by Trudy Small from our center, and the main message here is you're looking at kids on the left, adults on the right. You see that the overall CD4 recovery is much better in the children than in the adult patients. And then in the black spots, those are patients who had opportunistic infections. And you see that there's many more opportunistic infections in the adult population, and especially in the patients with low CD4 counts. And so you see a direct link to also in transplant patients between CD4 count and the risk of infection, and the other fact that the adult patients have a harder time recovering their immune system, and that's because of involution of the thymus. This is data in cord blood transplant, where infections also are critical, and you can see that over time after transplant, the rate of infection decreases, although in red, which is illustrating viral infections, you see that those tend to persist. And you see again, this correlates with the recovery of the immune system. So as the immune system recovers here in CD4 counts, the rate of infection tends to decrease. What about vaccine responses? I mentioned the recovery of B cells. Well, in order for a vaccine to work, you need B cells to make antibodies, but you also need CD4 help, T cell help, to help the B cells work. And so what this shows here, this is again from our center looking at vaccine responses over time. And this is the HIV vaccine, this is Prevnar, and you can see that the response to the vaccine decreases with the age at transplant. And we know that the older patients are more at risk of these types of infections, and they don't respond well to the vaccine. And we're also able to show here that the ability to respond to vaccine correlates directly with the naive T cells. So patients who can make naive T cells are more likely to respond to vaccine. And this is taken it one step further. This is looking at the thymus. So this test, which is called TRECs, basically gives you an idea of what the thymus can do. And in this study from our center, you can see that in the black squares represents the children, that's under 19, and this curve represents the adults. And you can see that either far out after transplant, that the kids are making many more TRECs than the adults. So their thymus is still healthy and is able to make useful cells. And then when we look at the implications of that, we're looking here at infections and TRECs, so thymic activity. And you can see again, in the kids, you have better thymic activity. The better thymic activity actually correlates with the risk of infection. So you can see this is the people who do have TRECs, the people who have low TRECs, and the people with low TRECs have a high rates of infections. And this is also true for CMV. So we're seeing more CMV infection in patients who have less thymic activity. So it's all tied in. It's the ability of the thymus to regenerate, which helps the immune system recover, helps the immune system fight infection, and helps the immune system also respond to vaccines, which can prevent infections. Going back to the repertoire, this is also our work where we're looking at the diversity. And you can see that in a healthy individual, you have the typical Gaussian curve of distribution, which shows that the T cell repertoire is sort of very well distributed. Whereas in the patient, you typically see this kind of thing. There's one specific clone that is very developed, but the rest of the T cells are suppressed. And so again, we're seeing this diversity issue. And this is looking at it now in a cohort of patients that we studied. And what we wanted to do here is look at patients who had conventional transplants using tacrolimus methotrexate for GVHD prophylaxis, patients who had T cell depleted transplants. So those patients don't get any immune system, any T cells in the graft, but they also don't get any drugs because they're at much lower risk of GVHD. Compare this to cord blood grafts and to healthy individuals. And I want to make 2 points here. Number one, we looked at CD4 and CD8 T cells separately, and you can see immediately that the level of diversity, which is pictured here on the left, is much higher in CD4 cells than in CD8 cells. And so we're starting to see a lot of data come out using this type of technology, and in fact I'll be chairing a session tomorrow afternoon for those of you who couldn't escape, where I'll talk about the use of next generation sequencing in immune recovery. And many investigators are looking at whole T cell populations. And I think it's important to recognize that if you do that, really what you're studying is CD4 T cells, because the CD8 T cells are lost in the mix. The other point I want to make here is that you can see that when we look, for example, at the T cell depleted transplants or the conventional grafts, between 6 and 12 months there's a significant increase in recovery. So we're seeing increasing numbers, but we're also seeing increasing diversity. And we believe that for the immune system to work, you don't just need numbers, but you need functional T cells and you need a diverse population. What are some of the factors that affect immune recovery? Well, ATG is certainly one of them. This is anti-thymocyte globulin that's used in several regimens, and that basically is developed against the thymus. So not only does it affect the thymus, it also affects T cells. And so what happens after that is, and this is a study using conventional grafts, where they looked at immune recovery at day 30, 31 to 60, and then beyond that. And you can see that there's a significant decrease in recovery of the immune system in the ATG group here versus the non-ATG group. And most of these were statistically significant. And when we looked at our data set, in the 350 patients who underwent T cell depleted transplant, where we also used ATG in patients, we saw that the patients who had ATG had also decreased immune recovery. So to summarize this part, the factors affecting immune recovery include the fact that the thymic involution associated with advanced patient age, the conditioning regimen can impact the thymus, particularly when you use radiation, the graft source can affect immune recovery, HLA disparity between the donor and the recipient, as well as the use of T cell depletion, and this could be done either in vitro through CD34 selection or in vivo using drugs. And obviously, graft versus host disease and the drugs that we use to treat or prevent graft versus host disease also affect immune recovery. And particularly, we're starting to recognize that graft versus host disease can actually affect the thymus as well. And so traditionally, we thought of GVHD as being an issue of the gut, the liver, and the skin, but now we're recognizing increasingly that it's also an immune-compromised situation because the thymus is directly affected by GVHD. And in addition to that, we add all these drugs that then further suppress the immune system. So what can we do about helping the immune system recover? This is just a sample of things I found on the internet or that I've had in my inbox, as I'm sure you've had. I was very gratified to see that some of them are even organic, which we all feel strongly about. But I do want to make this disclaimer that I'm not endorsing any of these products, and I have no shares in any of these companies. But this is the way I think about immune reconstitution. Not as sexy, but I think a little bit more realistic in terms of what we can do clinically. So we can work at the thymic level, we can work on peripheral T cells, we can work in the bone marrow, and we're even starting to generate lymphocytes or precursor lymphocytes or thymic equivalents in vitro. And so there's really a whole, I would say, research area right now where we're trying to sort of regenerate immune systems in vitro that we can then transplant into patients at the time of the stem cell transplant. And so there's a number of drugs that are either being tested clinically or being developed clinically that can help immune reconstitution. And I just want to illustrate an example with one of the studies that we did, Interleukin 7 or IL-7. This is a drug that's required, or this is a cytokine that the body makes that's required for T cell development, both at the level of the thymus as well as T cells, and it also maintains healthy T cells in the body. It's been shown that in mouse models it can help immune recovery, and we've also seen in studies of patients with solid tumor or HIV that it can increase both CD4 and CD8 T cells. So we did a lot of the preclinical work with this drug, and obviously we're very excited to take it forward clinically. We did a phase 1 study in patients after stem cell transplant, treated 12 patients with escalating doses. And what we saw in these patients is that the CD4 count went up in most patients that were treated with the drug. It's a once-a-week injection under the skin. It's given just like Neupogen, and that's how I actually explain it to patients. It's the Neupogen for the immune system. And what you can see here is that we basically saw a doubling of the CD4 count within the space of 3 weeks for patients who were treated with this drug. And when we look at CD8 T cells, we saw the same doubling of the absolute CD8 count. And importantly, I told you that numbers is one thing, but we want to see quality as well. It's not just about the quantity. So one of the patients that I treated on this study had CMV reactivation. So she had CMV viremia that was controlled with valganciclovir, and we put her on the study. And what happened was, we were fortunate that she was A201, so we had tools to look at the immune response to CMV. And in particular, we had a tetramer, which I spoke about earlier. And you can see this has CD8 response to CMV. The hashed area is the treatment period. So when we first start, she has no T cells against CMV. And then she has a dramatic rise in CD8 T cells against CMV once we start the drug. We were able to take the patient off valganciclovir, and she had no further reactivation of CMV. So though this is not a direct proof that the drug did this, I think it's very suggestive that by in helping the immune system recover with IL-7, we'll be able to generate a functional response against the virus. And I think it's further supported by this patient who was treated on the study of IL-7. So this is a patient who got his IL-7 and then developed EBV PCR viremia. And in many of these patients, the presence of EBV in the blood is just a prelude to developing a full-blown lymphoma, post-transplant lymphoproliferative disorder. And so these patients were usually very aggressive about treating. And so when his PCR went up, we immediately admitted him to the hospital since he was on an investigational study. We did a CAT scan, PET scan, found no activity. He was completely asymptomatic. And so we made the decision to not treat him and just watch him. Because we typically use Rituxan in these patients and it's quite effective. But because he was completely asymptomatic and all the scans were negative, we thought we'd sit tight. And unfortunately, his PCR went down completely. So this patient resolved his EBV without any therapy. And then again, we were lucky, he was also A201. And so we had a whole series of tools to look at his immune response since we are very active in the EBV area. And this is his T cell response to EBV. And what's striking here is two things. Number one, he recognizes several different areas of the virus. So this is a very robust and healthy response. And number two, the percentages here are huge. This is the equivalent of the EBV response you would expect to see with somebody with acute mononucleosis. So if you have a teenager that develops mono, and then they finally clear the virus, this is the type of T cell response they have. So again, this is not a direct proof, but I think it's very suggestive that what happened is he got drug, his immune system started to recover, he developed EBV, and he was able to clear it by mounting a robust response. Typically, when we see EBV, if we don't treat it, it just keeps going up. And the final piece of data that I had for the IL-7 study comes back to this diversity. And here we're looking at the repertoire diversity. This is sort of pre and day 0. And you can see there's a few peaks and they tend to be lower. And you get a sense here that as we treat the patients at week 4 and then week 10 to 12, there's an increase in diversity. There's more peaks and valleys. And again, showing that the T cells are not just increasing in numbers, but we're also seeing more diversity and we're seeing more function. So I think we do have drugs that potentially may help us. And we're currently looking forward to develop this into a phase 2 study. So in conclusion, delays in immune reconstitution are associated with increased risk of infections, decreased risk of response to vaccines, recurrence of primary malignancy, development of secondary malignancies, as well as decreased overall survival, and strategies to prevent delayed immune recovery may improve outcomes after stem cell transplant. Thank you.